what other advancements do you see that might be coming into the future of titration and medication management? And do you see objective measures playing a role in it?
Yeah, I mean, advancements of, you hope that they develop, better, more effective medications. I mean, it's the first time there's a stimulant you can give at night that slowly titrates, and so in the morning, they're not off the rocker until they get their medication. And so hopefully we're making better medications that are more consistent, that are different delivery systems, maybe newer classes. And I think that we're always hopeful that we're going to just keep getting better and have better treatments. And I think back to the objective measures. I mean, there's so many times where, when they see it, where God, whether it's an adult for the first time and as a validation, I've been struggling my whole life. I felt like I've had to work harder than everybody else just to tread water and keep up, and this now validates it, and now they're excited. And again, I have it sometimes where you do the objective measure on the kid, and the parents are so blown away by that and the information you give them in that visual. Next, the next kids come in and they're like, and then the husband, and then the whole, and then because they all question, maybe we all thought we had it, and a lot of times everyone has it.
Well, it's I think it's still so many people don't know that this condition is more genetic than asthma. It's more heritable than asthma, and everybody acknowledges that allergies run in families, right? So, but it is more heritable than asthma. So it's not uncommon. And, some people say opposites attract. In some cases, birds of a feather flock together. And so mom and dad might both have it.
Yeah. Right. And sometimes it's validating to say, like they don't have it. It's listen, that's not your issue. So then we have to shift gears. Let's rule it out. And ruling out is, again, one of the most important things we do, is to make sure that you don't have it, and you don't have this, and we're not going to treat it, and we can figure out better ways to help whatever their goals are. And I think because people, a little bit of knowledge. How many times in a relationship I hear my girlfriend says I have ADHD because I never pay attention to her. I want to get tested. Okay, it's good. She tested. We do our thing. You don't have it. Then maybe there's another solution to your guy's problem. And I think, but you get that in married couples too. So sometimes it's like you said, I have a low suspicion, but this is something we can do to make sure
to really help. And having normal objective testing doesn't say with certainty that it's not there. But in my experience, it causes me again to put a hard stop and a pin into. And then go down to criterion E in the diagnostic criteria and say, what else could be going on here? And so every kid with a learning disability, for the most part, is going to have problems with attention in the classroom. So if you're a third grade student and really you're at the crunch time for learning to read and making sure that your reading fundamentals are established, and there's a lot of that going on in the classroom, and you have dyslexia, and you just can't do that. My experience is that kids will either class clown, shut down, or melt down, one of those three, and all of those outcomes lead to suspicion of ADHD because disruptive behavior or oppositional behavior and that emotional response, but it may not be coming from ADHD. So the dyslexic child will have a perfectly normal QB test because it's not language-based. Whereas any of the other testing that is used, psychological educational testing, which in my opinion should not be used for the diagnosis of ADHD as a general rule, because I don't have to have an IQ or learning disability test to rule out ADHD. It's not language-based. So the kid with dyslexia that doesn't have ADHD is going to do fine on a QB test. And we have definitely stopped medication and then ask the parents to reevaluate what was the effect of the stimulant. And so often the parents come back and say, well, the teacher says she's much more engaged.
And I think it helps because, there's a lot of overlap. And I say one of the, probably as a very common question for school-age kids, is this anxiety or ADHD? Because it looks a lot alike. I mean, if you're anxious, you're kind of head on a swivel. You're kind of the hypervigilant. You're hard to sit still. You're doing threat assessment. You're really not focusing on what the teacher is, and having obviously good good clinical interview, get collateral information, listen to everyone, how they describe things, and then having an objective measure that can say, hey, look at this. Like I know you scored perfectly in all these different things. Like it helps sometimes determine whether or not it's a mood or anxiety disorder, and we need more of this, and this is one of the few things where I can do a test, help again, it's not the ultimate in the diagnostic, but it helps me, and then I could do treatment, and I could actually show you that it's better. And I always joke, so my father's an orthopedic surgeon, and I said, Dad, you had it easy. You took a picture, told him it's broken, and you take a picture, tell him it's healed. You have that, and we're still working on that, but these are the things that I think are going to be the advancements and things like this, because we need better ways of doing it, because screening tools and assessments are just that, and we need better objective measures. Yeah.
And measure, hopefully with technology, the improvement in technology, we can measure some of these same parameters in the real world environment, because it's one thing to pay attention in our clinic in a room that's dedicated to do the testing, right? It's another thing to really assess in the real world.
Mm-hmm. Well, I'm glad you mentioned that, because so the paper I commented about that we wrote earlier, looking at our QB-Check data, that was actually done remotely.
Right.
So all of the QB-Check assessments were done remotely, both baseline and post-treatment follow-up. And so that's also looking at them taking responsibility, doing it in their own home, in their own setting and not in a clinic setting, and being able to assess their progress,
Because that's where life is lived, right? Exactly. In their environment. Yeah. I've always said it's a little bit like, so as helpful as it is, doing it in the clinic is a little bit like getting the blood sugar normal in the hospital, but the kid's going to go home and have a different environment in terms of exercise and diet. Mm-hmm. It's not going to be a prescribed hospital diet and no activity. And so it can be a really great measure, but it would be better. One of the advancements, I think, would be like QB-Check.
Yeah, and looking at, QB-Check and other, potential remote treatment monitoring tools, I think will just continue to strengthen your arsenal of tools to use for making a more confident and accurate diagnosis, right? It's like putting together furniture. You can do it with a screwdriver and, put some elbow grease in and you got it, or you can use an electric drill.
Right.
And feel a little bit more confident about sitting down in that chair.
Right.
Right? But that does get me excited to think about the potential advancements, remote testing, to be able to monitor, patients' progress, adherence, compliance.
Well, it's the way medicine in general is going, right? I mean, whether you're looking at technology to improve healthcare outcomes, is something that's happening across the board.
Yeah. And again, it's about making it easier and faster. Like I wish that every kid could get a comprehensive neuropsychological assessment. We would learn a lot about how their brain works, how they react to things emotionally, socially. It's great. Those are valuable tests. They are done by very highly trained and few and far between people. They take time because it's hours of test, and then there's a write-up, and it makes it hard because you would love for that, and it would help us so much, but it's hard to wait for all that time. Where with a good clinical interview, a more focused question, and something you can do in your office in 20 minutes. That's what we have that, and neuropsych will always have a place, and
absolutely,
I'm a big fan of it. And there are times where after I do my assessment, I think I need to send you for that kind of testing.
And I agree with David 100% on that, because it sounded like I was saying that was not necessary. It certainly is necessary, very often. But it's not necessary to get at an ADHD diagnosis. It's more necessary to find out what's tagging along with the ADHD, if anything.
Right. Yeah. The underlying learning disabilities
or other neurological things that tag along with ADHD. So the insight that testing provides is wonderful. But again, if you do that testing with the ADHD dose optimized, you see it through a different lens, right? So very often when the testing is done before dose optimization, what you're seeing is the impact of ADHD on for example, on the intelligence testing, processing speed and working memory. And so you're not getting a true picture of the child's ability because the ADHD is driving those parameters down. And so you can't do a pre and post neuropsych evaluation. And, you can't, they're really, as David said, they're not resources to do the first one. Yeah. You certainly can't go back 6 or 8 months later or 5 months later when the child's
a few weeks later,
or even in a lot of cases it can be a few weeks later. Yeah. But I can perform a QB test that's going to give me age and gender norms as well as compare to the to that particular child or adult's baseline.
Right, and I think it's a really good starting point, like you said, too. There's such a Venn diagram, right, of overlapping disorders in this category. And if we can either rule in or rule out, one fairly confidently, right, or at least give you a clearer picture or direction of which circles you can veer away from, right?
Right.
I think would, like to your point, save on time and resources, which are limited at all levels here of the process. And cost, of course.
Cost is a huge variable.
Absolutely. So I really appreciate your time today, talking with me and joining us to discuss, titration and medication management. And anything else you'd like to add before we wrap up?
Well, I think one of the things that we hear in clinic from folks that have been treated elsewhere is we've tried everything. And the parent really does feel as though they've tried everything. Would you agree, Dave? I mean, they really do. And what they've tried is 3 medicines all in the same class at low dose. Or they've tried 3 doses of one medication. And so I would just like to end by saying there's hope out there, don't give up. The success for ADHD treatment when medication is titrated appropriately, and by success I mean really good symptom control, having the network well connected for focus, is really attainable with minimal side effects almost all the time. And so if you haven't gotten there, don't give up. It can be, as David pointed out, it can be a frustrating process. People call it trial and error. I like to call it trial and learning. So with each medication trial and each dose increase or decrease, we're learning something about that child's neurology and metabolism for the medication. And as long as we're getting closer to the goal of optimal treatment, then that is time well spent, in my view. And sometimes it's easy, and we love those patients.
Yeah, and again, sometimes, I say you start low and go slow, but slow is relative, and too slow is a motivation killer. I mean, if, for example, you start them on a low dose and it's not effective, and for some reason, it's been a few weeks and nothing, maybe the kid starts giving up on it, and the parent gives up on it, and yet if they see the results faster, that's definitely great. And then, I think the other flip side is sometimes people are too aggressive, and they have their thing where, like, I'm going to get every kid up to 50 milligrams of my favorite medication because that's where we see the average effective dose. And then, then that also leads to things. And again, back to you, I so often get that from parents, and I say, can you get me their pharmacy records? And I've seen that they've been on a little of a lot, not a lot of anything. And again, there was no sort of adequate follow-up or play. And again, there could be a lot of factors to that, but I think keeping people motivated, sometimes them seeing the data themselves, seeing where they change, how they've changed, how they've improved, that can be a very powerful thing for some people because it's a visual that you can give them, saying you went from the 99th to now you're testing normal. Like, that's awesome.
I was thinking back to clinic last week, and the number of times I hear a parent say, "Oh, wow," after looking at the comparison test, it's just like it just hits them because you can really see in between the two the difference, and if they understand what the test is measuring, which they can understand pretty quickly, very often it's so apparent, and it's really rewarding to hear them gain that understanding.
Yeah, that's wonderful. Well, thank you both
Thank
so
you.
much.
Thank you
Really
for the
appreciate your
opportunity to
time.
talk about this.
Definitely.